फाउंडेशन डे लेक्चर सीरीज में आप सभी का बहुत बहुत स्वागत है। आज हमारे साथ है डॉक्टर नारायण शाहने सर, जो कि नडियाद गुजरात से है। सबसे पहले भगवान धन्वंतरी वंदना से इस सत्र का आरंभ हम लोग करते हैं, उसके बाद मैं उसके डिटेल्स शेयर करती हूँ आपके साथ। तो आपका स्वागत है सर। शेयरिंग ऑप्शन दीजिए नवीन सर। डॉक्टर जोशी सर।
शंखं चक्रं जलौकां दधतमृतं घटं चारुदौर्भिश्चतुर्भिः सूक्ष्मं स्वच्छातिरुद्यं शुकपरिविलसनम् मौलिमम्बोजनेत्रं कालाम्बोद्योज्ज्वलाङ्गं कटितटविलसश्च चारुपीताम्बराढ्यं वन्दे धन्वन्तरिं तव निखिलगदमिव प्रौढदावाग्निलीलम् प्रौढदावाग्निलीलम्।
नमस्कार डॉक्टर नारायण सर, आई एम ऑडिबल? डॉक्टर नारायण जी आप हैं? आर यू देयर? डॉक्टर नारायण शाहने सर, आर यू देयर? आवाज आ रही मेरी सभी को? डॉक्टर तृप्ति जी, अर्शिया?
यस मैम,
ओके ओके, तो स्वागत है आपका। आज हमारे साथ है डॉक्टर नारायण शाहने जी, जो कि ब्रह्मा आयुर्वेद के डायरेक्टर है, जो नडियाद गुजरात में है। एंड ही इज ऑनररी आयुर्वेदा कंसल्टेंट फॉर द रिस्पेक्टेड ऑनरेबल गवर्नर ऑफ गुजरात। सो a very well known personality.
I'm sorry ma'am, but still you are not audible.
No sir, I am audible to all. I think your audio is not connected. See, I'm audible to all the participants, and you are also audible. सर स्वागत है, वेलकम वेलकम ऑन दिस प्लेटफॉर्म। नमस्कार सभी को। तो वी आर वेटिंग एंड वी आर ईगर टू लिसन यू सर ऑन दिस स्पेसिफिक सब्जेक्ट यूरोलॉजी, एंड आई होल हार्टेडली वेलकम यू।
Thank you ma'am, thank you so much.
Yes, so you can continue with afterwards we will have a question answer session. So and this is our second lecture on this occasion of Ayush Darpan Foundation Trust 8th Foundation Day. So welcome sir.
Thank you ma'am, thank you.
You may continue your session with PPT sharing or as per your convenience.
Is the screen visible?
Yes.
Okay. So first of all, thank you very much ma'am and Ayush Darpan Foundation for inviting me and giving this opportunity to share this particular branch of Ayurvedic urology in front of you. So without wasting much of time, already we are running a little late, so better to start with the proper topic. Om Namo Bhagavate Vasudevaya Dhanvantare Amrit Kalashastaya Sarvamay Vinashaya Trailokyanataya Mahavishnave Swaha. O Lord Dhanvantari, please shine something upon us so that we can reflect the world. The topic which we are going to discuss today now is Ayurvedic Urology, the most amazing and promising branch and evidence-based approach. First of all, welcome to Brahma Ayurved, world's first and only Ayurvedic Urology Center. It's not that only we claim, but we are world's first and only Ayurvedic Urology Center, working in the field since almost last 20 years. The diseases on which we work especially are listed over here, and these are urethral stricture, benign enlargement of prostate, post-urethral walls, post-TRP status, bladder outlet obstruction, interstitial cystitis, recurrent and multi-drug resistant UTI, hypotonic bladder, neurogenic bladder, and incontinence, etc. Now, the most prominent disease of this area is supposed to be urethral stricture. Urethral stricture means there is blockage inside urethra. This kind of, like this is the diagrammatic picture, and this is ascending urethrogram of one of our patients. You can clearly see that there is constricture at this level and at this level as well. So basically, as far as the etiology is concerned, there is a long list, but out of which these are the common causes or etiological factors which lead to stricture formation. These are urinary tract infections, urolithiasis, trauma on lower urinary passage, Vegadharana, and unsafe sexual practices. In fact, it is believed in urology that almost 50% of cases of urethral stricture are iatrogenic. That means resulted from instrumentation and surgeries, etc. That means, in other words, almost 50% cases of urethral stricture are generated by a hospital. This is very unfortunate, but at the same time, very true. Now, to know the nature of the disease, first of all, we need to understand the exact nature or quality of urethra. So basically, urethra is not a rigid pipe like any metal or PVC pipe. It is a very soft and collapsible pipe. So collapsible pipe means which remains closed for 24 hours. It opens only when a person passes urine, and as soon as urine is passed, it closes or collapses again. So being a collapsible pipe, it has got its two distinct qualities. One is elasticity with which it can open up and close, and the other one is caliber. Caliber means the maximum extent to which that pipe can open up is called as the caliber of that collapsible pipe. And these two qualities are very important for the normal function of urethra. Now, as far as the pathology is concerned, it's a quite complex process. So initially, there is some kind of noxious stimulus in the form of either bacterial, chemical, or physical form that causes denuded epithelium, that leads to squamous metaplasia, ultimately fissure development in epithelium, and extravasation of urine, and development of fibrosis in corpus spongiosum, fibrotic plaques coalesce, and ultimately stricture is formed. So this is quite complex. To simplify this complex process, okay. So you must have seen that whenever there is any wound or ulcer on any epithelial lining of the body, eventually that wound heals. And when it heals, it leaves a scar. And if you have observed it properly, the scar left is much smaller as compared to the actual size of the wound. That means any wound contracts significantly. This is called a cicatrization of the wound. So any wound contracts significantly. So obviously, whenever there is a wound inside the urethra, the tube, which is a very small tube, even that wound is going to get contracted. And while contracting, that wound, while contracting, constricts the whole pipe of urethra. This is the first part of pathology. Now, the second thing, whenever there is any wound or any epithelial lining of a body, even in case of deeper wounds, that wound heals by the process of granulation. Now, generally, when the granulation reaches the epithelial lining, naturally it stops over there. Normally or generally, no hyper or over granulation is seen. So generally the process stops at that level only. Now, in case of urethral wounds, obviously, urethra carries that salty acidic urine many times a day. And obviously, while flowing through it, that salty acidic urine interferes the process of granulation. So it is interfering that granulation, the process of healing again and again. the most important part is healing is again a natural process. So when nature realizes that this particular wound is not healing properly, nature tries her best to heal that wound at any cost. And in that attempt, the rate of granulation increases significantly. And that's why there is always some kind of hyper or overgranulation. So obviously, it grows inside the lumen, like in different forms, like mucosal fold or iris constriction, or this kind of short segment or even linear structure. So once it grows inside, obviously it reduces the lumen. Now this hypergranulation gradually turns into fibrosis, which is rigid, which is also called as actual scar tissue of the structure. So once it turns rigid, the elasticity of urethra at that particular part of urethra is lost. Once the elasticity is lost, the ability of that pipe to open up means caliber is also lost. So two important qualities, elasticity and caliber, are lost. This is what is called as urethral stricture disease. The symptoms of lower urinary tract, the symptoms in short are called as lower urinary tract symptoms, LUTS. There are three different classes of LUTS. The first one is storage LUTS, means while the bladder is getting filled, these symptoms are observed. These are like frequency, urgency, nocturia, different kinds of incontinence like urge, nocturnal, stress incontinence, gender incontinence, and pelvic pain. The second one is voiding LUTS. In this class, like the symptoms are observed while passing or voiding the urine. And these are incomplete emptying of the bladder, episodes of near retention, voiding small volume, spraying or double stream of urine, hematuria, burning and dysuria, straining, hesitancy. Means it that person takes longer time to start the flow of urine, starting problem. Then poor flow, dribbling, intermittency, etc. Intermittency, a flow which starts, stops. And the third one is additional LUTs. And these are hemospermia, presence of or expression of blood with semen, retrograde ejaculation, while performing sexual activity, instead of getting out, that semen goes upwards towards the bladder, that is called as retrograde ejaculation. Discharge from urethra, reduced ejaculation force, pain in the scrotum or testicles, dyspareunia, painful sexual act, and fever with chills and rigors. So these are the symptoms. The diagnosis is made obviously with proper history taking to know the exact point from where the stricture, the pathology would have started, and a thorough clinical examination. Along with that, there are some special investigations, including retrograde or ascending urethograph or urethography. In that, a radiopaque contrast is introduced into the urethra as it is ascending. That's why it is called as ascending urethrogram. Then, while introducing that, X-ray snap is taken, and that clearly shows the constriction at different levels if it is there. The other one is micturating cyst. In this, they introduce a small, maybe an infant feeding tube into the bladder, and then the bladder is filled with that radiopaque contrast, and the patient is asked to void urine. And while voiding or passing urine, this X-ray snap is taken, called as micturating or voiding cystourethography. Those are very clear-cut investigations to diagnose the stricture, to confirm the stricture. As far as female patients are concerned, till date, even in the textbook of urology, there is a concept of only micturating cystourethrogram. Now, for a female to perform a micturating cystourethrogram in an X-ray room, that too in front of that X-ray technician, and that too while standing, is quite difficult, very embarrassing. So obviously, it is not performed well. That's why we tried the same ascending urethrogram in some of our female patients with one of our senior friend, a radiologist from Nadia, Sonic's clinic. So we tried there. When we tried, we found really very good results. Almost the whole length of urethra can be visualized even in ascending urethrogram. This is much more convenient for a female patient. As here you can see this ascending urethrogram of one of our female patients. There is a constrictor at this level, at the tip of this adapter, and again from here onwards, here upwards, means the ascending. Here this part, he's also, you can see a very thin line leading towards the bladder. So Even this can be used, and now we have a significant amount of data of female ascending urethrogram, and we are spreading the word in the field of, in the community of radiologists. This is again very important investigation. In fact, it is absolutely a non-invasive investigation called as uroflowmetry. In that, that patient has to make sure that his or her bladder is full, and that patient has to pee into a tub which is attached to a PC system, and this graph is generated. Now, in this graph, few things are very important. The first and most important thing, this max flow rate or Qmax. So this should be at least 15 ml per second. In this case, it is only 4.9 ml per second. The average rate, flow rate should be around 10 ml per second. Here it is only 2.5 ml per second. The post-wide residue urine is 140 ml in this patient, which is very significant. It should be insignificant or minimal. And the graph, here you can see it is very much compromised near to the baseline. In fact, it should be just like the bell pattern, bell in a temple, or at least a flat box type design. As far as the treatment is concerned, the conservative treatment is only palliative or symptomatic. Yes, one can go for urinary divergence, but it is temporary in the form of either suprapubic catheterization this way or a perineal urethrostomy. But this is definitely temporary. This perineal urethrostomy is done only in case of very dense and linear strictures of urethra, or patients who suffer with even cancerous strictures. Now the option remains is of only surgical. Now the first option is urethral dilatation. Either it is done with metal or Teflon dilators, or sometimes with balloon dilator. Now basically, when they do, actually it is done under anesthesia. So initially a small dilator is introduced, maybe 6 or 8 French. Then gradually the size is increased. It is introduced, removed. Then the next size is introduced, removed. So obviously, whenever there is rigidity inside the urethra, that fibrosis is there, obviously the dilator will not enter in easily. So obviously that urologist or surgeon has to force it in. And if he has to force it in, that causes new injury inside. Once a new injury is caused, obviously the pathology which we learned earlier restarts, and that's why gradually stricture recurs. So generally, after dilatation, that stricture recurs within 1 year. And that's why that dilatation is posted near the birth date of that patient to remind him or her that now is my birthday and now I have to go for the dilatation. That's also called as birthday dilatations. Now, in fact, nowadays, nobody does it in the private sector. It is done only in the government hospitals. The most widely used technique to open up a stricture nowadays, supposed to be the gold standard, is urethrotomy, visual internal urethrotomy, or direct visual internal urethrotomy. To open up that constricture, either a urethrotomy, simple blade, or cold knife, or different types of lasers, including holmium, thulium, are utilized or used. Again, to open up that constricture, it has to be cut. If a cut is taken, a new wound is formed. Once a new wound is formed, the pathology, which we learned earlier, restarts. The wound contraction, hypergranulation, fibrosis, the same thing. And that's why even after this VIU, generally within 1 year, the stricture recurs. So to maintain the caliber, most of the urologists, they explain that patient to go for clean intermittent self-catheterization. Means that patient is taught to introduce a catheter into urethra on her or his own. Now again, this being a blind procedure, again, the way a doctor does it in the hospital, a normal person, a normal human being, a layman will not be able to perform it back home with that care. And obviously, there are certain complications are associated with this particular CIC, and those are recurrent UTI, injury, rupture urethra, new scar formation, multiple strictures, even and false passage. Like this is ascending urethrogram of one of our patients. You can clearly see this is the normal passage of urethra leading towards the bladder. And this is false passage. This guy was doing the CIC since more than 8 years. And this false passage was generated. So even after going through this, actually, ideally, the way it has to be done is Initially, it has to be done every day. Then the frequency has to be reduced from every day to alternate day to twice a week to once a week to fortnightly to monthly. But as soon as the patient starts reducing the frequency, it gets harder for him or her to introduce the catheter. Then either he or she has to reduce the size of the catheter or again increase the frequency. And even after following this sincerely, that patient has to go for neck surgery within around 1 year. So it is there. So that's why, like after going through 2 or 3 erythrotomies, generally most of the urologists advise to go for erythroplasty, which is supposed to be the last resort for the management of urethral stricture. Erythroplasty. It is an open surgery, a major surgery. There are different types of erythroplasties, including end-to-end erythroplasty or end-to-end anastomosing erythroplasty, and another one is buccal mucosal graft reconstructive erythroplasty. In fact, the BMG, buccal mucosal graft reconstructive erythroplasty, is very famous. In that, the constricted part of urethra or the fibrous part of urethra is completely excised, and the buccal mucosa, the inner skin of the cheek, the buccal mucosa is utilized to reconstruct that much part of urethra. That's why called as buccal mucosal graft reconstructive erythroplasty. As of now, Dr. Sanjay Kulkarni from Pune is supposed to be the authority for erythroplasty in India and Indian subcontinent. And we have got many patients who underwent erythroplasty at his center. Is the nature of the disease, because in this, there is a bigger wound. Once there is a bigger wound, obviously, that wound again, the same pathology recurs, pathology appears there, and that's why the stricture recurs. And that's why by now, what we learned is very clear to conclude that results of conventional urological treatments are not really very promising, and treatment of urethral stricture remains a challenge despite of those much advancements in so-called conventional urology. In fact, it is believed in urology that once is a stricture, always is a stricture. Urethra is supposed to be the most egoistic part of human body, so one should never ever disrespect urethra. So already, like we learned that with a small disrespect, with a small wound, the pathology of stricture starts. And if a person is like again disrespecting it again and again and again, that stricture, that fibrosis turns really very hard. So this is all about the urethral stricture disease. So what we have to offer in Ayurveda or in Ayurvedic urology? This treatment, Uttarbasti, then calibration of urethra, then some oral medications. Obviously, we use only Ayurvedic medications for most of our patients, like Rakta, Medo, Pachak, Pat. There are 9 basic ingredients. Rakta, Pachak, 5. Patol, Sariva, Musta, Patha, Katuki. And Kiratiktam, Amruta, Chandanam, Vishwavisham, 4 drugs, Medo, Pachak. So combination of Rakta and Medo, Pachak drugs. Then Oshirasau as a systemic alkalizer and tablet Sanshmani. Just a moment, I'm extremely sorry, but Dr. Mukul Patel, Vice Chancellor of Gujarat University, is calling me. Let me tell him that I'm in a meeting. Sorry. Good morning, sir. हाँ सर, कितने बजे आने वाले आप? अच्छा, ठीक है सर, करते हैं ऐसा कुछ. मैं से एक्चुअली लेक्चर में हूँ, ऑनलाइन लेक्चर चल रहा है मेरा, तो उसके बाद फोन करो सर मैं आपको प्लीज. हाँ चालू है अभी लेक्चर, ये खत्म होते ही मैं फोन करता हूँ सर डेफिनेटली आपको. थैंक यू सर, एक्सट्रीमली सॉरी. So this is like Raktamedo Pachak, which we are using since years, and which is like we have seen that this is the best antimicrobial agent of Ayurveda, which we are using since years. Now the actual process of Uttarbasti, the way we perform Uttarbasti is like this. For this, no catheterization is required. So basically in this, it's very important that the whole procedure must be conducted under very rigid aseptic precautions. For Uttar Basti, one should never ever introduce a catheter into urethra, because instrumentation is one of the important causes for structure formation. So one should never introduce a catheter. And this only, we use this Foley's adapter. So only this is 1 inch longer, and we introduce half of that into urethra, and then the medicine is gradually pushed. What are the medicines used? It is an oil-based medicine. We prepare our own medicines. Even the medicine is sterilized, keeping in this glass bottle. We put that glass bottle into autoclave cooker in a drum, and it is sterilized. Wherever possible, we use disposables, and rest of the things are sterilized with proper standard autoclave technique. While introducing the medicine, it has to be really very gradually and gently, because we are working on most sensitive part of human body. That too, we are introducing something against the natural passage. That's why the possibility of vasovagal event is very high. We have seen and managed many vasovagal events while performing Uttar Basti. So it should be with due respect and care. It has to be introduced very gently as possible. By introducing the medicine, it is absolutely painless, so no anesthesia is required. While introducing the medicine, we ask that patient to go for deep breathing, because deep breathing enhances secretions of endorphins from cerebral cortex, and endorphins help to manage that little discomfort and pain. They are naturally occurring analgesics. They also help to prevent the vasovagal event. After introduction of the medicine, we fix that penile clamp. We keep it there for maybe 5 to 10 minutes to keep that medicine, the maximum concentration inside urethra, for some time. The whole medicine, generally we introduce 6 times of the medicine. The whole medicine goes to the bladder, and from there it works. In case of female, we do the same. Initially, I used to use the central nozzle gas syringe, but now we are using the same Foley's adapter to introduce the medicine into female urethra and bladder. In case of females, we ask that female to lie down cross-legged after introduction of the medicine for 5 to 10 minutes. After the procedure, the patients are asked not to micturate as long as it is easily possible. Once they get the urge, they can pass urine at any time. Now, these are the drugs we use. Actually, we have classified and we prepare Siddha Tel of different drugs. Like the first group is the Lekhana Dravya Siddha Tel, then Vrashodhana Rupan, then Mutra Dosha and Vasteanantaka. Lekhan mainly helps for the debridement of that fibrosis, that fibrotic tissue. Vrashodhana Rupan, like we now know that urethral structure is a kind of non-healing ulcer. So we need to address that. So this Vrashodhana and Rupan helps for that particularly. Then the Mutra Doshahara. This especially addresses the inflammation or the inflammatory process inside the lower urinary passage. And the Vastamantaka, mainly for urothelial regeneration, to strengthen the bladder, to boost the immunity of local tissues by boosting the organism tissue barrier. Along with that, we also use fresh prepared Panchavalkal Kath, Nisha Nimbadi Kath. Generally, for most of the patients, we do 20 settings of the treatment. So initially, we go for one uroflowmetry before commencement of the treatment. Then initial 5 days, only Uttar Basti, that too mainly with Lekhan Dravya Siddha Tel. From 6th day onwards up to 12th day, we do Uttar Basti and Uttar Basti plus urethral calibration under local anesthesia on alternate day. On 6th day, generally we introduce 10 and 12 French catheter. On 8th day, it is 12 and 14. On 10th day, it is 14, 16, and 12th day, it is 16, 18, and 20. Actually, when we are able to introduce 18 French catheter with ease, that means we achieve the normal caliber of urethra. But just to make sure, we introduce one extra size, that is 20 French, to make sure that the whole fibrosis is removed. In fact, when the urologists do the dilatation or surgery, they open it up to at least 22 French, sometimes 24, even 26. I have seen a patient whose urethra was opened up to 28 French size. Why? Because they know that very soon it is going to constrict again. But again, the thing is, to open up urethra is not a big job. The main thing is to keep it open to maintain the caliber without any kind of treatment afterwards. And that is what we are doing since last 20 years. I'll show you some cases as well. So generally on 14th day, we go for follow-up uroflowmetry. In fact, the patient can observe the improvement in the flow and symptoms from 6th day onwards. And here it is evident in the uroflowmetry as well. From 13th day onwards up to 20th day, there is only Uttar Basti. Now the way we do the calibration is like this. Initially, we introduce the medicine of Uttar Basti, then we introduce that anesthetic agent, lignocaine gel. We use disposable Nileton catheters for calibration. By doing calibration, we are trying to restore the caliber of urethra. So the 4 settings which we done on 6th, 8th, 10th, and 12th days are called as calibrations. So this is actually, there is color code on different catheters. For this patient, this is the last calibration. Here we are going to introduce this 20 French catheter. So at the end of the catheter, there is yellow color. This is 20 French. There is color code, standard color code. So when we introduce it, it should be very gentle as possible. Again, this also is absolutely painless, because the medicine used in initial 5 settings makes the fibrosis so soft that the catheter can go in very easily. Now the color code is accordingly, like 20 is yellow, 18 is red, 16 is orange, 14 is green, 12 is white, and 10 is black. This color code. It's not only that while introducing, but even while removing the catheter, it should be very gentle. One should never ever forget that urethra is supposed to be the most egoistic part of human body, and one should never ever disrespect urethra by any means. And here you can see the catheter is absolutely bloodless, not even little blood stain is there. So it is absolutely bloodless. I can confidently say that for more than 95% patients, the calibrations are bloodless. Yes, for less than 5%, yes, we observe some hemorrhage in different forms, but generally that hemorrhage stops on its own. Why? Because as we learned, urethral stricture is a kind of non-healing also. So whenever there is kind of active wound inside, or there is significant inflammation inside, even that inflammation sometimes causes this kind of bleeding. Otherwise, for more than 95% patients, it is absolutely bloodless. And even after this, patient need not to rest. That patient can resume his or her daily routine immediately after the procedure. So this is the best part of this procedure. There are certain very important precautions for Uttar Basti. Though it seems to be a very simple procedure, but it has to be performed with due care, with due respect, and with due precautions. The first, which is really very important, is the proper assessment of the patient. Why this is necessary? Like many people think that why it is necessary. So the answer is here. Like I can show you this. This is the ascending ureterogram of one of our patients. Actually, he is a CISF guy, Central Industrial Security Force guy. He was like resisting to go for ascending ureterogram, because most of the time when the patients go for ascending ureterogram, most of the radiologists and their technicians, they push that contrast with pressure. They push it hard, because they have an impression that unless and until they push it hard, the whole length of urethra will not be visualized. So with that impression, they push it hard, and that causes severe pain, sometimes bleeding, sometimes UTI. And that's kind of like literally horrible for the patients. Like going for an investigation is that painful. So it's quite like disturbing for a patient. So most of the patients, they avoid to go for this investigation. For us, it is very important. We never start the treatment without this particular investigation. Why? Here you can see, when we send this guy for the ascending ureterogram, you can see the whole contrast which was introduced inside the urethra was absorbed into these veins. So intravasation. And you can see the internal iliac vessel on this side, right side, is very prominent. Even here on left side, it is also visible. That means the whole contrast was absorbed into the vessels, into the veins. So if we would have started his treatment without this investigation and would have introduced that oil-based medicine, the whole oil-based medicine would have entered into the cardiovascular system, resulting into a severe fat embolism. That's which is a fatal condition. quite serious. So one should always remember that one should always do the proper assessment of each and every patient undergoing Uttarbasti treatment. Then well-informed and convinced patients and relatives. We have a policy that unless and until each and every patient and the relatives are absolutely satisfied, we never start the treatment. We are open for any kind of discussion with the patients. We haven't seen any like significant ill effect of this treatment since last 20 years. Little complications are associated with that, like that kind of vasovagal events are very common. Then urinary tract infections are also very common, even though we like here we perform the procedure under very rigid aseptic precautions, but sometimes already the patient is carrying infection, sometimes that flares up. So that is there. Otherwise, there are no like significant complications or side effects of this patient. That too, if you assess patient properly. Rigid aseptic precautions are very important. Even the sterilization of medicine is very important. Then expertise, very gradual drug introduction, because we are doing it without anesthesia. It has very sensitive part, so it has to be done with that due respect and care. Then at least portable pulse oximeter should be there while performing Uttarbasti, ideally multi-paramonitor. For many patients with like, especially the patients who are apprehensive, patients with comorbidities, generally we give a shot of injection atropine as an anticholinergic agent before the calibration especially. And for many patients who are apprehensive or again, patients with comorbidities, generally we keep an intensivist standby since last many years. And all the necessary things to manage vasovagal event, including laryngoscope, endotracheal tube, drugs to handle emergency, and obviously oxygen cylinder. The results of Uttarbasti are assessed clinically and by comparison between pre and post treatment investigations like urethrophy and uroflowmetry. The results of Uttarbasti are irrespective of the site, size, extent, and etiological factor of the structure, and this is the most beautiful part of this particular therapy or treatment. Okay, let me present you some of our cases. I would say one of the most complicated and challenging cases of my career till date. This lady from USA, basically a Punjabi lady, but US citizen since long. She was suffering with stricture since more than 12 years and has to undergo urethral dilatations every 6 months. Otherwise, she used to suffer retention. Unfortunately, she suffered retention on 15th October 12. And when she approached nearest emergency in California, when they tried to introduce catheter, the urethra was not at all negotiable. Then they tried to introduce an infant feeding tube, but even with 6 French infant feeding tube, urethra was not at all negotiable. Obviously, they have to go for suprapubic catheterization as an emergency treatment to evacuate the bladder. After a series of investigation on 17th of December 12, she was advised to go for cystoscopy and vaginal flap urethroplasty, as already she underwent multiple dilatations. So directly she was advised to go for urethroplasty. When they posted the surgery on 23rd of January 13, I have got all the operative notes of this patient from that operating surgeon, Dr. Christopher Elliott. When they tried to introduce a pediatric 10 French cystoscope, they could cannulate urethra for hardly 0.5 centimeter. Then they tried to negotiate urethra using a guide wire, which is thin like the ball of a ball pen. But even with that wire, urethra was not at all negotiable. Then they tried that suprapubic approach, introducing a flexible ureteroscope, and through that they tried to introduce a guide wire. But even through that approach, urethra was not at all negotiable. So obviously they have to abort the procedure, and they explain that lady that she has to lead rest of her life with this tube only. Now, especially for most of the people, once the doctors of US say that there is no hope, that means there is no hope at all. So what next? Her daughter searched on the net. She got our site. The name itself is cureurethral-stricture.com. There is an online consultation form. She communicated with us. It was very hard for them to believe an Indian doctor, that to an Ayurvedic doctor, says that it is curable. How come? And as I mentioned earlier, that we have a policy that unless and until each and every patient is absolutely satisfied, we never start the treatment. So ultimately, that lady came to us. We started her treatment on 20th of April 13. Within 10 days, we were able to remove her suprapubic tube with normal flow of urine. A lady who was unable to pass even a single drop of urine, that lady passed urine with a max flow rate of 16.8 ml per second. We should be 15 at least. With an average flow rate of 12.4, we should be around 10 ml per second. With a normal uroflow, flat box step design, and that too without straining. So this particular case, in fact, till date, it is believed in urology that it is simply impossible to open up a stricture without surgical intervention. And this particular case proves the possibility of opening up of that this kind of tie stricture without surgery, without surgical intervention, with this particular treatment of Uttar Basti and calibration. Not only this, but after completion of the treatment in May 2013, she went to USA. She came back after 3.5 years of her treatment. She especially came to see us. We performed her uroflowmetry, and even at that time, her uroflow was normal, maintained, without any kind of treatment afterwards. A lady who has to undergo dilatations every 6 months. A lady who has to undergo dilatations every 6 months. That lady led a normal life without any kind of treatments for almost 3.5 years. And it's been almost 10 years. That lady is leading absolutely normal life since then. So this case disproves the belief once is a stricture, always is a stricture. This case, a patient from Maharashtra, a farmer, suffered complete retention. Obviously, urethra was not at all negotiable, even with infant feeding tube and suprapubic catheterization was done. Prostate wasn't that significant to block the passage of urine. It was only grade 1 prostate. And he was advised to go for urethroplasty. You can see his ascending ureterogram. There is a complete tight stricture, impassible stricture at verumontanum. When the radiologist tried to push that contrast with little pressure, you can see the extravasation, but still dye didn't enter the bladder. So it was absolutely an impassible stricture. He was advised urethroplasty. Then he came to us, we started his treatment. Now for all such patients, what we do, we try to introduce the medicine through urethra as gently as possible, and remaining medicine we introduce through the suprapubic tube, and then we keep that suprapubic tube clamped. And we ask that patient to try to void urine naturally so that it makes passage. Now look at this patient passing urine like this. Then I took the patient to the same urologist, in fact, a very leading urosurgeon of Nanded. I performed this case when I was chief resident in Nanded, Government Ayurveda Hospital. I took this patient to him. I requested him to see this patient. I requested him that I want to show your patient, but it's a request that you should come into the washroom. And I showed him the flow, and the way he explained was either it is impossible or it is a miracle. So immediately I replied him, sir, first thing, this is possible. Even you can say, so this is not impossible. This is definitely possible. And again, sir, it is not a miracle. It is a science. Because like whenever somebody stamp this particular thing as miracle, that means it is absolutely like with no base, which is absolutely unscientific. So I said, so no, sir, this is absolutely scientific. And since then, I'm trying to prove this as a scientific treatment, and the main aim of this overall mission is to establish this particular treatment of Uttar Basti as the first and universal line of treatment for urethral strictures. So this is his follow-up ascending ureterogram. You can see initially it was completely blocked. Later it is completely wide open. The contrast entered into the bladder as well. Then we removed his suprapubic tube, leading normal life afterwards. This guy, basically from Chennai but living in USA, a software engineer, underwent first surgery in November 11, VIU, visual internectomy. Within 1 year, the stricture recurred, has to undergo second surgery in December 12. When he came to us in December 13, the flow was significantly compromised. It was 9.3 ml per second only. After our treatment, that improved back to normal 18.8 ml per second. He went to USA in December 13. He came back in December 17 after 4 years of his treatment. And even after 4 years, his uroflow is absolutely normal. Again, it's been 9 years. He is leading absolutely normal life. So this is how there are, like, we have got number of such cases. This guy from Iraq, Kurdistan, teacher by profession, underwent VIO on 16th November 13. Unfortunately, within 20 days, the symptoms relapsed with severe dysuria. When he came to us, you can see the flow was very badly compromised. The graph is near to the baseline. It was that bad. And after treatment, that improved back to normal, leading absolutely normal life since then. We have such patients as well. Like, we have treated this kind of patients, 1, 2, 3 laser VIU, 1 urethroplasty. Even after urethroplasty, there are again different laser VIU, and still after going through these much surgeries, we are doing CISC every day, and still the flow was very much compromised. After our treatment, that came back to normal, leading normal life since then. So we have a number of patients of this condition. Definitely, we have many modern doctors as our patients, many surgeons, gynecologists, physicians, pediatricians, and I can definitely and proudly say that a kind of cherry on the top or cherry on the cake, one of our patients is a urologist from Mumbai, and he's also leading normal life since maybe more than 5 years. Regarding the results, here you can see the mean Qmax before treatment was 6.3 ml per second. After treatment is 21.7 ml per second. And this is based on the assessment of almost 244 patients. Now, out of 244 patients, it's not that all are doing absolutely well. Some patients came back with relapse of symptoms after some time. And like out of 244, only 32 patients, means 13.1% patients came back with relapse of symptoms after some time. So for such patients, like, we are maintaining a separate data. Obviously, those patients who came back with relapse of symptoms, we did additional 7 settings of Uttar Basti for them. And they were also very specific, like the patients who underwent multiple surgeries after multi-stage hypospadias repair, who were on regular CIC since long, patients with BXO, post-buccal mucosal graft urethroplasty status, post-TRP status, and who have very hard suture scar tissue. Such patients, obviously, complicated patients, though they have to come back, but it is a safe treatment. There is no surgery. And after going through the next additional settings, now they are leading normal life. So just let me present you one such case in front of you. So this particular patient underwent hypospadias repair in 89, which is known to cause stricture. And you can see that in the same year, he has to undergo VIU. And after that, he has to undergo dilatations every 3 months. Again, second VIU, again 3-month dilatation, again third VIU, dilatations every 3 months, fourth VIU. And the condition was so bad after fourth VIU in 2008 that he has to undergo dilatations every 15 to 20 days. And each time it was very painful with severe hematuria, burning pain, dysuria, fever with chills and rigors. Now, when actually, he was very much frustrated, depressed. His life was like hell. When he came to us for the first time in June 15, you can see his flow is absolutely normal because he came to us immediately after the dilatation. We treated him with 20 days treatment. You can see his flow lasted up to October 31st, October 15. For 4 months, it was normal. In December, after 6 months, it started getting compromised. We again treated him in December 15. That flow lasted up to December 16. So first time it lasted for 6 months. Second time it lasted for 1 year. And again, it started compromising. So we managed him in December 16, January 17. Flow is absolutely normal. And since then, since January 17, December 17, June 21, his flow is normal. Until date, he is leading normal life since January 17. So for a person who has to undergo dilatations every 15 to 20 days, and that person is leading absolutely normal life since January 17. Definitely, this is really very good for him. So in our field, it is believed that pressure is important. Just let me present you just one more case. And after that, I'll conclude, because it's very like difficult for me to justify this huge topic within maybe 50 minutes or 60 minutes. So just let me explain you this one case, this bladder outlet obstruction or bladder neck obstruction. Actually, it is a blockage at the base or neck of the bladder, which reduces or stops flow of urine. Now, as far as stricture is concerned, it is a kind of actual structural obstruction. In this, it is kind of functional obstruction. So basically, what exactly happens? We need to understand the apan vayu. Basically, apan vayu is an energy which holds urine up to certain limit, means unless and until almost 400 to 500 ml of urine is collected in the bladder, we are unaware of that. And once that much quantity is collected in the bladder, we get the urge. As soon as we enter the washroom, two things occur simultaneously. The detrusor muscle, the bladder muscle contracts. At the same time, the external uterus sphincter relaxes. So the contraction of the detrusor muscle and relaxation of the external uterus sphincter is called as detrusor sphincter synergy, and the flow of urine starts normally. Now, in the cases of this particular bladder outlet obstruction, this synergy is disturbed and called as detrusor sphincter dyssynergia, DSD. Now you must have experienced a transient type of DSD, especially while traveling maybe by a bus and your bladder is full and though the driver is not halting. Maybe it takes 1 to 2 hours and then he halts, and when you try to avoid, though the bladder is really very full, but still at that time, the flow is not really very good. It's not only the flow, but you need to apply pressure to empty the bladder. And even after passing urine, you feel that you didn't get the satisfaction of passing urine. So krute api akru sangyata is there. So that is kind of transient DSD. But when a person like does it again and again, then there are many people who try to hold urine again and again because of the busy schedule or some other reasons, and that turns into a permanent DSD, detrusor sphincter dyssynergy, ultimately bladder outlet obstruction. So let me present the most challenging case of my career till date. This kid, 9-year-old kid from Ahmedabad, was carrying an impression in the mind that the washrooms in the school are not really very clean and neat. So he used to avoid passing urine in the school. He used to hold urine. He used to start from home by around 7 o'clock and used to come back by 3 o'clock, and he used to hold urine for those much hours continuously. Vegadharan, that bad Vegadharana. That led to severe LUTS, including overdistended bladder. Actually, literally, his bladder was 2 inches, visible above 2 inches of umbilicus. It was that huge bladder, with typical hesitancy, poor flow, incomplete emptying of bladder, and overflow incontinence especially. And he was also suffering with constipation because of Vegadharan, with that specific history of Vegadharan. Look at the MC of that kid. Here you can see this huge bladder. So the radiological diagnosis was, here you can see a kind of cut of urethra. Actually, this is the level of external urethral sphincter or urogenital diaphragm. So the radiological diagnosis was either a very tight stricture at this membranous level or urogenital diaphragm level, or this is typically in radiology, this is called as spinning top appearance, a toy. So this is diagnostic of post-urethral walls. So this was the radiological diagnosis, either a tight stricture or post-urethral walls. The sonological diagnosis, you can see the pre-void volume was 1081 ml, means more than 1 liter, that huge bladder. The bladder capacity at that age is around 300, max 350 ml. So it was more than the thrice. So it was very bad, and the post-void was 836 cc. So the sonological diagnosis was neurogenic bladder with significant back pressure changes, hydronephrosis and hydroureter. It was very significant. The uroflow was very much compromised. Qmax was only 4.2 ml per second. He could void only 40 ml of the urine. And he was advised to go for cystoscopy and VIU or post-urethral valve fulguration as an emergency treatment to preserve the kidneys, to address that particular diagnosis. But for me, the differential diagnosis is very important. Actually, the post-urethral valves are diagnosed at an early age, around within 1 year of the life. So to be a case of post-urethral valve at the age of 9 was most unlikely. Again, the tie stricture which was found at the erogenal diaphragm was mainly because of that vague dharana. So it wasn't true. Then the neurogenic bladder, even it wasn't the true because that kid was holding it. There wasn't any significant or specific neurogenic factor to cause the neurogenic bladder. So for me, it was a known case of severe bladder outlet obstruction, vague dharana janya udavarta. And we started his management with Uttar Basti, urethral calibration, Anuvasan Niru and Kshira Basti, double widening. Now, for all such patients who have got significant post-wide residue, especially for kids, especially the kids who are suffering with post-urethral valves, that helps significantly. Double widening means once that kid passes urine, that kid has to come back and again has to pass within 10 minutes of that initial voiding. So that helps to reduce that post-wide residue significantly. Then Avagaha Swed and some oral medicines. We started his treatment on 17 January 22. Within 8 days, you can see the pre-wide, which was initially 1081, that reduced to 460 ml. The post-wide, which was 836 initial, that reduced to 123 ml. And the back pressure changes improved significantly. This is the note by the same sonologist who performed his initial ultrasound. The flow also improved from up to 11.5 ml per second. He could wide 130 cc. And later, after 22 sittings of the treatment, you can see the post-wide is only 4 cc, and the whatever the back pressure changes were there, they were completely resolved within 22 days without surgery. And here you can see the flow is also normal. We took his follow-up after 6 months of his treatment and leading normal life. There is no even little trace of back pressure changes. The post-wide is only 19 cc. The flow is absolutely normal. Here you can see the 15.4 ml max flow, absolutely normal. So it is believed in urology. In fact, it is very important that one should never ever hold urine, because it is believed by all urologists that passing urine saves your life. So vague dharana is not at all good for anybody. So never ever try to hold urine. Vague dharana is dangerous. Passing urine saves your life. So actually we manage many conditions, but because of the time constraint, I'll not be able to justify those diseases. So ultimately, whatever the disease we are just going through, they have like no promising treatment in so-called conventional urology. And in Ayurveda, yes, we have in Ayurvedic urology, we have very promising non-surgical and quick treatments. We had a group of Japanese doctors at our institute in May 18 under the leadership or guidance of Dr. Harishankar Sharma sir and Dr. Hiroi Inamura ma'am from Japan. So we conducted a crash course of understanding and applications of basic principles of Ayurveda and Panchakarma at our institute. Then I was invited to Japan to deliver a lecture on Ayurvedic urology. Again, this Japanese urologist, she came to our institute. Different doctors from different countries, from Russia, from Singapore, Egypt, and Algeria. They visited our institute to know what exactly Ayurvedic urology means and what exactly we do in Ayurvedic urology, and they really appreciated the way we are working in this field. A small introduction of our institute.
Welcome to Brahma Ayurved, Gujarat's first ever multi-speciality Ayurvedic hospital with world-class standards. Founded by Doctors Jui and Narayan Shahane, we have multiple theaters well equipped for urology, proctology, Ayurveda, and Panchakarma. For patients staying over, there are multiple beds, ranging from common to VIP, with special facilities. Guests receive excellent, healthy food and access to an on-duty doctor around the clock. Here you can receive the best of modern healthcare combined with the age-old wisdom of Ayurvedic medicine. We receive many local and international patients for highly specialized procedures such as the Uttar Basti, an effective cure for urethral strictures, performed in our Ayurvedic Urology Center, the first and only in India. Brahma Ayurved. Follow the most authentic and updated science of life.
Thank you very much. Thank you everybody for giving me this opportunity, especially the Ayush Darpan Foundation and especially Shilpa ma'am for giving me this opportunity to present this unique wisdom of Ayurveda in front of you. Thank you very much. And I can proudly just want to share one thing that now I'm official Ayurveda consultant to Governor of Gujarat since last few months. So it's a proud moment for all of us, for our Ayurveda community especially. Thank you. Thank you so much. And now the topic is open for discussion, for queries.
Yes. Thank you, sir. Thank you. So kind of you. And very nice presentation, and congratulations being a consultant. It's a really proud thing as you belongs to Maharashtra and Marathwada. So it's really a proud moment for me too. Yeah.
Thank you.
So I welcome all the doctors for discussion. And it's really wonderful to listen you especially the cases and the results. And it will really build up the confidence of newcomers, as they are very much worried about the urinary system and the diseases related with. So Dr. Shashi, please unmute kariye and you can ask your question.
हाँ जी मैम, थैंक यू मैम। सर से पूछना था कुछ चीजें। पहले तो मैं कॉन्ग्रेचुलेशन करना चाहूंगी सर को कि सर गवर्नर हैं, कि मतलब फिजिशियन है, जो राज्य वैद्य हमारे यहाँ डिफाइन होता था आयुर्वेद में। तो सर उसके लिए बहुत बहुत बधाई के पात्र हैं आप, और हमारी पूरी आयुर्वेद फ्रेटर्निटी उस चीज के लिए है। और बीइंग आयुर्वेदिक मतलब स्कॉलर मुझे बहुत अच्छा लग रहा है इस बात का। दूसरी एक चीज और मुझे अच्छी लगी जब आपने अपने मतलब सिस्टम का दिखाया कि आपके यहाँ आयुर्वेद का मल्टी स्पेशलिटी है। तो मेरा एक्चुअल में सपना था जब मैं कॉलेज में थी कि आयुर्वेद का भी होना चाहिए, क्योंकि वेदांता, अपोलो, ये सब सारे हम लोग बड़े बड़े हॉस्पिटल एलोपैथ के तो देखते हैं, मल्टीपल ब्रांचेस होती हैं, लेकिन आयुर्वेद में बहुत रेयर जगह एक पर्टिकुलर कोई कर रहा है अलग बात है, लेकिन अलग अलग ब्रांच के फॉर्मेट में जो अष्टांग आयुर्वेद हम कहते हैं एक छत के नीचे हो और करें उस तरीके से, तो वो वाकई बहुत अच्छा लगा मुझे। दूसरी चीज है सर, उत्तर बस्ती के केस में एक्चुअली मुझे पूछना था आपको। जैसे उत्तर बस्ती के केस में है कि क्योंकि गायनी में भी मैंने बहुत काम किया, तो हम तो वहाँ सिंपली क्या करते हैं भाई, स्टेलाइज कैथेटर रहता है और कैथेटर पुश कर दिया यूरेथ्रा में। तो अभी आपने जो बताया उसमें ये था कि फॉलिस एडाप्टर लेकर करना है, कैथेटर ऐसे नहीं डालना है
जी।
तो सर वही मैं, क्योंकि अपने सेंटर पर तो मैं इस तरीके से नहीं किया, गवर्नमेंट में तो बहुत काम उस तरीके से किया हुआ है, तो मैं अपने सेंटर पर भी उत्तर बस्ती वगैरह शुरू करने के लिए कोशिश कर रही थी। तो क्या ये फोलिस एडाप्टर लगा कर करना ज्यादा बेटर है, मतलब कि देन हम सिंपल यूरेथ्रा डालना चाहते हैं, कुछ भी फ्लूइड डालना हो तो, मतलब उत्तर बस्ती फॉर्म करना हो फ्लूइड का मतलब हमारा
I have already mentioned that instrumentation, any kind of instrumentation inside urethra is not at all good. So one should never ever disrespect urethra. So it is definitely, in fact, it is believed in urology that almost 50% cases of urethral stricture are iatrogenic. So why to go for that instrumentation when you can do it without catheterization? That's polytherapy only. So that is definitely always better.
नहीं सर, वो तो आपकी बात अच्छी लगी। जैसे जब हम गवर्नमेंट हॉस्पिटल में डिलीवरी वगैरह करते हैं तो डिलीवरी के टाइम भी डाल दिया जाता है, और
अच्छा,
सिंपल सा।
You are asking regarding that? मतलब वो
हाँ,
क्या?
मतलब मेरा कहने का मतलब वही है कि जैसे हम लोग जब अभी तक डालते थे कैथेटर, हमें पता है कैथेटर स्टेलाइज्ड है, तो दिमाग में ये नहीं रहता था कि कुछ भी इंजरी हम वहाँ करेंगे। हालांकि कभी भी ऐसे केस भी नहीं हुआ कि कुछ भी ब्लड लगा है, या मतलब वो एक सिंपल प्रोसीजर की तरह हो जाता था। तो अभी आपका देखने के बाद मुझे लगा, क्योंकि जैसे यूटीआई के केस में कुछ डॉक्टर्स वगैरह हैं, फलगृत की उत्तर बस्ती देते हैं और तुरंत रिजल्ट आता है, विद इन 5 मिनट आ जाता है। तो वही मैं सोच रही थी, जैसे मान लो फलगृत की भी उत्तर बस्ती में देना है, तो ये फॉलिस का डॉक्टर लगा करके देना ज्यादा सेफ है देन सिंपल कैथेटर से।
Obviously, फॉलिस एडाप्टर से ही।
ओके सर, थैंक यू सर। मेरा यही मेन क्वेश्चन था, क्योंकि मैं अपने सेंटर पर हर चीज बहुत प्रिकॉशन के साथ करना पसंद करती हूँ। तो थैंक यू सर, बहुत बढ़िया लगा, आपका प्रेजेंटेशन भी बहुत अच्छा था, काफी कुछ नॉलेज आया। और सर एक क्वेश्चन और पूछना चाहूंगी मैं, जैसे एक 65 ईयर के ओल्ड मेल पेशेंट है, उनको पहले फैटी लीवर ग्रेड था, 1 था, सॉल्व हो गया था, फिर उन्होंने कुछ मिथ्या आरबीआर किया साल भर के बाद, फिर उससे उनको फैटी लीवर ग्रेड 2 डेवलप हो गया, साथ में प्रोस्टेटोमेगाली है, और साथ में उनको सर अभी 2 to 3 मंथ बैक इंग्वाइनल हर्निया डेवलप हो गया। तो ये जो प्रोस्टेट वगैरह का केस है, उनकी मेन कंप्लेन सिर्फ ये है कि रात में 3 से 4 बार उन्हें यूरिन के लिए जाना पड़ता है। तो क्या उनके केस में भी उत्तर बस्ती दी जानी चाहिए?
जी, हम करते हैं रेगुलरली। एक्चुअली अभी समय काफी कम था और इतने सारे सब्जेक्ट पे क्या क्या दिखा है, क्योंकि ये अकेला स्ट्रक्चर ही ऐसा है कि जिसके लिए कम से कम 2 घंटे का लेक्चर चाहिए आइडियली। तो
नहीं सर, बहुत अच्छा लगा कि बहुत सारे डाउट्स मेरे क्लियर हो गए। मैं फ्रैंकली बता रहा हूँ, सिंपली अल्ट्रासाउंड देख करके हम लोग कई बार काम कर लेते थे। तो ये जो आपने बोला ना कि AUG था, तो मैंने कहा मैं भी आगे से ये करा करके ही पेशेंट को हाथ लगाऊंगी, तो इसलिए मैं उनके केस में उनको सिंपल बस्तियां तो दे रही हूँ। तो क्या उनके केस में उत्तर बस्ती
अकेले उत्तर बस्ती से लाभ नहीं मिलता है, तो उत्तर बस्ती के साथ आपको योग बस्ती भी कराना चाहिए पंचकर में।
हाँ, वो तो चल रही है, मतलब सिंपल बस्ती का मतलब है कि हमारी ये जो कर्मकाली योग वाली बस्तियां हैं वो उनकी चल रही हैं, उत्तर बस्ती नहीं
कर सकते उत्तर बस्ती। जैसे प्रोस्टेट के लिए एक अलग से प्रेजेंटेशन कभी चांस मिला तो हम करेंगे, पर प्रोस्टेट में ऐसा होता है कि only in case of severe symptoms we go for उत्तर बस्ती and योग बस्ती, otherwise that can be managed with medicines only, especially if the nocturia is very high, रात को कई बार उठना पड़ता है पेशेंट्स को,
हाँ सर, मेन प्रॉब्लम वही है,
flow significantly compromised है, so in that case only we go for उत्तर बस्ती and rest of the treatment. अदरवाइज मेडिसिन से भी इम्प्रूवमेंट काफी अच्छा मिलता है उसमें। अभी हम एक्चुअली कुछ मेडिसिन डेवलप कर रहे हैं, वेरी सून वी आर गोइंग टू लॉन्च दोज मेडिसिन, खास करके प्रोस्टेट के लिए भी, जो हमारा एक्सपीरियंस 1 साल का उसके बेसिस पर काफी सारी चीजें यूरोलॉजी में लॉन्च करने जा रहे हैं। तो वो बहुत ही स्पेसिफिक टू द पॉइंट, मतलब टारगेटेड थेरेपी काइंड ऑफ हो गया वो।
ओके, नहीं जैसे मैंने उनको पहले एनीमा वगैरह भी दिया है, क्योंकि मैंने नेचुरोपैथी भी की है और आयुर्वेद की भी स्कॉलर हूँ, तो उस वक्त उनको काफी अच्छा रिस्पॉन्स आया था, बल्कि और जब मैंने अपनी बस्तियां दी तो उनको उतना नहीं आया। तो मैं वही चाहती हूँ, मेन उनकी एक ही, और कुछ नहीं बताते हैं कि फ्लो कॉम्प्रोमाइज है या कुछ भी, मेन उनका रहता है कि मैम दिन में मतलब रात में 3 से 4 बार उठना पड़ता है, तो ऑब्वियस सी बात है नींद कॉम्प्रोमाइज हो रही है,
मतलब
तो वो चीज उनकी ना हो।
ये क्यों होता है, क्योंकि ब्लैडर इज नॉट गेटिंग एम्प्टी कंप्लीटली, तो पोस्ट वाइड रेसिड्यू सिग्निफिकेंट होगा उनका।
ओके सर, तो अभी तक कराया नहीं था मैंने उनका टेस्ट।
जब प्रोस्टेट का एनलार्जमेंट होते हैं तो 2 चीजें साथ में होती है, एक तो इट कंप्रेसेस द यूरेथ्रा, सेकंड that causes kind of bladder outlet obstruction, and second thing is, it pushes the bladder base upward, तो ब्लैडर बेस अपवर्ड पुश होगा तो उसके चलते रेसिड्यू काफी अधिक रहने लगेगा, इसलिए ब्लैडर पूरा खाली नहीं होगा, तुरंत भर जाएगा, इसलिए फिर से जाना पड़ेगा, ये होता है। और फ्लो भी कॉम्प्रोमाइज होता है, सो बेस्ट वे आउट इज यू शुड गो फॉर वन यूरोफ्लोमेट्री एंड पोस्ट वाइड रेसिड्यू यूरिन, सो दैट विल गाइड। चलो ठीक है, कितना मतलब फ्लो कैसा है, नॉर्मल है या नहीं है, अगर नॉर्मल नहीं हो तो डेफिनेटली यू शुड गो फॉर उत्तर बस्ती एंड कैलिब्रेशन आल्सो, हम वो भी करते हैं प्रोस्टेट के पेशेंट को।
ओके सर, थैंक यू सर।
Any more questions, doctors?
हाँ, मुझे पूछना है मैम। हेलो
हाँ,
सर,
yes,
बहुत
yes.
बहुत बहुत अच्छा लेक्चर हुआ, मुझे तो पता ही नहीं था इस टाइप का भी कुछ होता है। मैं तो रिक्वेस्ट करूंगी कि अगर हो सके तो आप पूरे ऑल ओवर इंडिया ही ऐसे कुछ ब्रांचेस आपके स्टार्ट करें, जैसे पतंजलि, माधव बाकी होती है, वैसे ऑल ओवर इंडिया स्टार्ट करें तो बहुत ही अच्छा होगा, बहुत ही अच्छा था। सर मुझे 1-2 डाउट थे। जैसे सर अभी कई लोग होते हैं कि रात को सोने के पहले वेग आया हो या नहीं आया हो तो भी यूरिन को जाके आते हैं, या कहीं बाहर जाना हो तो भी यूरिनेशन को जाके आते हैं, तो वो गलत है या सही है?
डेफिनेटली गलत है ना, आयुर्वेद बहुत ही स्पष्ट है, न वेगान धारेत न उदीरयेत
जी, ओके, तो नहीं करना है।
ठीक है। एक्चुअली वो जो होते हैं ना, आप जो कहते हैं कि जैसे बाहर जाने से पहले वो कुछ लोगों को बार बार, दैट इज ड्यू टू एंजाइटी। ठीक है, अदरवाइज जोर तो कभी लगाना नहीं चाहिए, क्योंकि जोर लगाना कभी भी अच्छा नहीं है ना।
जी जी। और सर रात,
जी
हाँ मतलब जोर नहीं, बस जाके आ जाते तो थोड़ा बहुत जितना भी हो तो वो कर लेते इस तरीके से
थोड़ा fear factor
ताकि
भी
उनको
होता है ना,
मतलब हाँ थोड़ा एक इसके सेटिस्फेक्शन के लिए
कंपल्सिव डिसऑर्डर टाइप में थोड़ा।
हाँ
खास करके फीमेल्स के लिए ऐसा होता है कि बाहर जाएंगे तो वॉशरूम मिलेगा कि नहीं मिलेगा, उस डर से जाते हैं।
हाँ,
ठीक है, वो
और रात को भी सोने के पहले जाके ही आ जाते हैं, ऐसे कई होते हैं।
दैट्स फाइन, बट वन शुड नेवर फोर्स, कि जोर नहीं लगाना है।
ओके ओके। और सर जैसे रात को कई लोग जाते हैं फिर आके पानी पीते हैं, फिर
नहीं।
जाते हैं, फिर पानी पीते हैं। तो ये पानी पीना बार बार और रात को सोने के पहले पानी पीना, इसके लिए ये ठीक है या नहीं?
बेसिक स्टैंडर्ड ये होता है कि पानी पीने के लिए जनरली ऐसा होता है कि जनरल थोड़ा सा अच्छा, मतलब इट्स रियली गुड क्वेश्चन। तो थोड़ा उसको और उसकी व्याप्ति बढ़ाते हैं, हम उसका स्कोप बढ़ाते हैं। देखिए ऐसा होता है कि पानी पीने के लिए जनरली सभी डॉक्टर्स या यूरोलॉजिस्ट ऐसे कहते हैं कि इट इज जनरली इन द फॉर्म ऑफ लीटर्स, कि इतना लीटर पियो, 3 से 4, 4 से 5 लीटर पानी। पर ये बहुत ही स्पष्ट है कि द नीड ऑफ वाटर ऑफ अ पर्सन्स बॉडी कैन नेवर बी डिसाइडेड बाय अ डॉक्टर, इट इज ऑलवेज डिसाइडेड बाय दैट पर्सन्स बॉडी ओनली। अब ये कैसे? तो जैसे कि यूरिन हमेशा पानी जैसा क्लियर होना चाहिए, पानी जितना लगभग, ये स्लाइट येलोइश टिंच है, दैट इज फाइन, बट इट शुड नेवर बी येलो, दैट्स द बेसलाइन। सो मेंटेन इट, लाइक इफ अ पर्सन इज स्टेइंग इन कोल्ड क्लाइमेटिक कंडीशन, जैसे बर्फबारी हो रही है वहां पे रहता है, तो शायद 1 लीटर भी पर्याप्त होगा उसके लिए, यूरिन को पानी जैसा बनाए रखने के लिए। और वही कोई मजदूर है, रास्ते में मजदूरी कर रहा है, धूप में मजदूरी कर रहा है, तो शायद 10 लीटर पिएगा तो भी यूरिन येलो आ सकता है। तो one should never ever unnecessarily burden the kidneys. So one should always observe the color of urine and just it should never be yellow. That's the basic standard. जैसे आपको येलोइश लगता है, आके वापस पर तुरंत पानी पी लिया 1-2 ग्लास, इतना सिंपल है, ऐसे ही सिंपल रखना है उसे। अच्छा, रात को, जहां तक रात का सवाल होता है, it is always better to avoid drinking lot of water after sunset. सूर्यास्त के बाद कम से कम पानी पीना चाहिए, जितनी आवश्यकता है उतना ही, शरीर जब मांगे तभी। अगर रात को उठ के फिर से पानी पियेंगे तो अगेन आपका ब्लैडर फुल हो जाएगा, फिर से उठना पड़ेगा। वैसे भी जनरली इट इज ऑब्जर्व दैट के द GFR, ग्लोमेरुलर फिल्ट्रेशन रेट, इज हायर ड्यूरिंग नाइट एज कंपेयर टू डे। तो वो नहीं।
Yes sir, thank you sir, thank you very much.
Any more questions?
Hello,
I think
sir.
it's a vast subject. Yeah. Yes,
Hello.
please.
यस
सर, न्यूरोजेनिक ब्लैडर और हाइड्रोनेफ्रोसिस ये कंडीशन क्यूरेबल है क्या सर?
हाँ, स्पेशली न्यूरोजेनिक ब्लैडर में हमें मिक्स रिजल्ट मिलते हैं। जैसे दोनों तरह से देखा है, कुछ पेशेंट में बहुत अच्छा इंप्रूवमेंट मिलता है और कुछ पेशेंट में, न्यूरोजेनिक के खास करके, उसके फैक्टर पर इंपॉर्टेंट है। कई बार क्या होता है कि जैसे कभी हमें नेक्स्ट टाइम मिला तो वो सभी टॉपिक पे डिस्कस करेंगे हम ज्यादा। जैसे इंटरस्टिशियल सिस्टाइटिस है, न्यूरोजेनिक ब्लैडर है, हाइपोटोनिक ब्लैडर है। तो कई बार हाइपोटोनिक ब्लैडर के केसेस को भी ऐसे लिया जाता है कि इट इज अ केस ऑफ न्यूरोजेनिक ब्लैडर, पर असल में न्यूरोजेनिक ब्लैडर होता नहीं है, किसी ट्रॉमा के चलते वो हो जाता है। न्यूरोजेनिक ब्लैडर बहुत ही स्पेसिफिक है, जिसमें वहां का नर्वस कंट्रोल ही क्या तो कम हो गया या चला गया है, तो वो कंडीशन लगता है। प्रॉपर न्यूरोजेनिक ब्लैडर जैसे स्पाइना बिफिडा के ऑपरेटिव में या स्पाइनल इंजुरी में होता है टिपिकल न्यूरोजेनिक ब्लैडर, तो उसके रिजल्ट्स बहुत मिक्स्ड मिलते हैं। कभी इंप्रूवमेंट होता है, कभी बिल्कुल भी नहीं होता है। हाँ, और हाइपोटोनिक ब्लैडर जिसमें ब्लैडर टोन इज रिड्यूस सिग्निफिकेंटली, इन दैट केस we get really very promising results. और ये हाइड्रोनेफ्रोसिस तो इट इज जस्ट अ बैक प्रेशर चेंज, बैक प्रेशर इफेक्ट। तो जैसे ही नीचे का जो ऑब्स्ट्रक्शन है, वेदर इट इज स्ट्रक्चरल और फंक्शनल, और जैसे ही नीचे का ऑब्स्ट्रक्शन चला जाएगा, फ्लो यूरिन का सेट हो जाएगा, नॉर्मल पे आ जाएगा, तो अपने आप वो बैक प्रेशर चेंजेस जो भी होते हैं हाइड्रोनेफ्रोसिस या हाइड्रेट रिजॉल्व हो जाएगा अपने आप। जैसे वो किड के केस में देखा ना आपने, जो छोटे बच्चे का केस प्रेजेंट किया था, सिग्निफिकेंट हाइड्रोनेफ्रोसिस हाइड्रेटर था, पर जैसे ही वो फ्लो नॉर्मल हो गया, रेसिड्यू कम हो गया, अपने आप वो रिजल्व हो गया।
Thank you, sir. Thank you very much. And we are looking forward for many more sessions because I think people are quite interested and your knowledge is quite good. So just last question, इतना डिस्कस कर लेते हैं।
मैम मुझे भी एक पूछना था बस।
हाँ, सपना बोलिए।
मैम सर, जो ये आपने बताया वो पॉलिस अडेप्टर ये यूज करते हैं सर, उसको स्टरलाइज करके रीयूज किया जा सकता है क्या? और
वो मेटल का है ना, जैसे बाकी सर्जिकल इंस्ट्रूमेंट मेटल के होते हैं, एसएस के होते हैं, उसी तरह से वो एसएस का है।
अच्छा, तो फिर उसको रीयूज कर सकते हैं स्टरलाइज करके। ओके ओके सर, थैंक यू।
सर ये केस समझा दीजिए इतना उनको, डॉक्टर सपना जी को, और फिर हम लोग वी विल कंक्लूड।
47 male with hypertension was back along with that is being came with CR. Actually, I'm sorry to say, but that is a case of nephrology, and I'm a urologist.
Okay sir, okay.
उनका क्रिएटिन है ना,
यस सर।
वो सीकेडी का पेशेंट है, क्रॉनिक किडनी डिसीज का टिपिकली।
हाँ सर।
हाइपरटेंशन भी जो होता है वो भी रीनल हाइपरटेंशन उनका टिपिकली दिख रहा है वो सब कुछ। तो एक्चुअली उसमें काम करते हैं पर इतना ज्यादा नहीं है काम हमारा ऑनेस्टली। और उसमें भी इफ द क्रिएटिनिन इज बिलो 4 रिजल्ट्स बहुत प्रॉमिसिंग मिलते हैं, अदरवाइज फिर इफ वंस इट एक्सीड्स 4 देन इट्स क्वाइट डिफिकल्ट टू मैनेज।
ओके सर, ओके, थैंक यू सर।
सो थैंक यू वेरी मच सर, थैंक यू सो नाइस ऑफ यू। एंड मैं सभी की तरफ से, आयुष दर्पण की तरफ से आपका आभार व्यक्त करती हूँ। और फिर जल्दी हम लोग सेशंस करवाएंगे आपके भी, एंड आई एम लुकिंग फॉर दैट वन आल्सो। सो
Sure,
थैंक यू
ma'am.
ऑल द वैद्यास आल्सो, थैंक यू वेरी मच।
थैंक यू।
थैंक यू मैम।